of this deliberation. Dr. Santanu Bagchi will be highlighting all those issues. Since it is focused on nursing participants, so I will request Dr. Santanu to focus and remain adherent to the areas which are very, very important for the nursing participant. And thank you, all the participants from the nursing faculty, nursing side, that they have joined this webinar and to get educated on this particular aspect of critical care management. So with these few words, Dr. Santanu, please go ahead. And we will be taking questions also from the participants, and we'll try to give answer adequately as and when it is required. So Dr. Santanu, please go ahead.
Thank you, sir. Thank you for the kind introduction, and thank you very much to Indian Society of Critical Care Medicine for giving me this opportunity to discuss some salient features of acute pancreatitis management in an ICU setup particularly. So without any further delay, let me proceed with the presentation today. Today's discussion will be focused more on the practical aspects of acute pancreatitis management. How does it, why does it happen? What is the pathogenesis? Little bit of that only. And mostly about the different controversies related to the management of pancreatitis, and particularly we'll try to focus on the nursing perspective while discussing all this. So first of all, this pancreas, as we all know, from the physiology point of view, it's a very benign, mild organ. It is working silently, just like our father in our house. So he's working or she's working very silently. It has some endocrine function, it has some exocrine function. With the endocrine function, it works in the blood directly, particularly our glycemic control, releasing of different enzymes, insulin, glucagon, all those enzymes are there. So that is there for the endocrine function. On the other hand, the exocrine function, there are release of multiple other enzymes directly, which helps in the digestion part. You have this amylase, lipase, and all sorts of enzymes are there. So mostly in a general setup and a general normal physiology, it's working very silently. You don't feel like pancreas is working. Your body is like systematized, homeostatized, like in that way that there is no such feeling. You never understand it is working. But this scenario changes. There is a big change happens once there is minor problem in the pancreas. So pancreas is not very forgiving, although it works silently, but it is not very forgiving. And once the patient goes into a state of acute pancreatitis, you will find the scenario changes dramatically. It's a complete haywire, complete mess. A patient with a severe acute pulmonary pancreatitis coming to your ICU, having all sorts of systemic dysfunctions. The patient can have respiratory problems, patient can have hypotension, bradycardia, hemodynamic instability, patient can be having dyspnea, breathing difficulty requiring oxygen ventilation, HFNC, BiPAP, patient can have abdominal distension, patient needs some CT scan, the enzymes might go up, patient needs fluids, patient needs analgesics, so many things are happening. So this apparently silent organ, when you irritate that organ, when it goes into a state of acute inflammation followed by a possible infection, the scenario changes completely. From absolute silence, it goes into absolute pandemonium. So that's why knowing the salient features of management of pancreatitis is very important. It is one of the bread and butter condition. I would say, I should not use that term, but it is kind of a very, very common condition we manage, we see in our ICU setup. So that's why it is very important not to miss the basics of the management of acute pancreatitis. And for that, you need to know a little bit of background also. So for today's discussion, we have taken an imaginary case. We'll proceed the discussion as the case proceeds. Okay. So here we are getting a middle-aged female being brought to your HDU with a chief complaint of upper abdominal pain for last 5-6 hours. That's all. And see how she is describing her pain, how your colleague, medical colleague, nursing colleague, doctor colleague who is there is taking the history. What is the type of characteristic type of pain, that history you are getting? So this pain is mostly, she is telling, this pain is mostly located in the epigastric region. It's sudden onset. It was not there even last night, but it started for last 4-5 hours only, acute onset. It is constant. It is not getting relieved mostly. It is constant there. There is a dull aching pain constantly present, and gradually the severity is increasing. And there is Sometimes this pain is getting radiated towards the back. So the pain is mostly acute onset, suddenly it is getting started, mostly located in the center part of the upper abdomen, sometimes getting radiated towards the back also, and usually it gets aggravated, like the pain is increasing with the food intake. She had something, some breakfast, light breakfast, despite the pain, and the pain got aggravated, and it got relieved on leaning forward. That is a characteristic history also she is giving. So this is the classic type of pain which usually you see in an acute pancreatitis condition, which we'll see subsequently. So one interesting or couple of interesting facts: this severity of the pain does not get correlation with the intensity. So extremely excruciating pain doesn't mean patient is having excruciating severe acute pancreatitis stage. Nothing like that. See, this is the difference with the chest pain. A severe chest pain, usually the more the pain, more the severity, there can be more the severity of the cardiac condition underlying. But here in acute pancreatitis, patient can be in the early phase of the acute pancreatitis and still can have a severe pain. So severe pain doesn't always mean patient is in the last stage of the pancreatitis. So there is one thing that you should remember. And if the pain location is different, like patient is having a lower abdominal pain, patient is having a colicky type of pain, which is getting shooted from upper abdomen to lower abdomen, then all those situations you need to think about some different diagnosis. Don't focus on acute pancreatitis straight away. So these two things to remember. Then coming back to our patient, she is giving some significant negative history also. Just like she gave a very nice history of the pain characteristic, she's giving some significant negative history also, like there was no fever, chills or rigor, there was no bleeding diastasis, there was no chest discomfort, palpitation or sweating was there. Patient was not having any recent history of LRTI or upper respiratory tract infection. There is no history of any burning sensation while passing urine, or doesn't give any proper addiction history also, neither any regular medication she has been on. Most importantly, there is no history of similar episodes in the running in the family. So these are the lots of negative history she is giving also. But with this, there is a significant positive history. What positive history? She is giving, telling that she underwent ERCP. ERCP must be a normal, known to term to most of you. It is endoscopic retrograde cholangiopancreatography. It is usually done when you are suspecting a gallbladder stone is obstructing the common bile duct. It is not being able to come out of the duct. So there usually you do a ERCP and then you try to extract the stone with that pathway. So that is how that ERCP was done on this patient couple of days back. So with all this negative history, she is giving a positive history also, that there was a history of ERCP being done couple of days back. Now, on examination, what you are getting, mostly on examination of this lady, when she has been brought to the HDU, the most of the findings was unremarkable, except there was some sort of tachycardia and mild decreased air entry in the basis. She is little bit dyspneic, but not needing any oxygen. And also there is some abdominal distension, which is tender on palpation. So there is some tachycardia, there is mild dyspnea, mild breathing difficulty, and some abdominal distension with tender abdomen on palpation. These are the positive findings you could get on the examination of the patient when she was brought in the HDU. Now, how do you strategize your management? What are the basic thing you should do? Ideally, this class should have been interactive, like you should answer me and then I'll proceed. But as probably that option is not there, all the participants being muted, you can put your questions in the chat box. And anyway, I would have been much better if you could respond also now. So see, I have to answer on behalf of yourself only. So a basic strategy for any acute condition, always never forget to start with our basic, that is ABC. What is ABC? ABC is airway, breathing, circulation. Whenever you are getting a patient getting admitted to an acute setup, either it is an ICU or it is an HDU, first see whether the A means airway, B means breathing, C means circulation is working well or not, whether the patient can protect his or her airway, whether patient can breathe properly, the ventilation is working. Ventilation means patient's normal breathing is functioning well, patient the good chest rise, there is no tachypnea, dyspnea is there, and simultaneously the circulation, the C where you will see whether the extremities are cold, clammy or not, patient is having any tachycardia, patient is having any hemodynamic instability. Those things you need to look for. So airway, breathing, circulation first to be looked, followed by simple basics. Put some IV cannulas because patient is not very stable. You need to go for, there is some abdominal problem there can be some abdominal unknown etiology, you don't know the diagnosis. So patient will require some sort of fluids, IV fluids, usually the crystalloids we give, because we cannot straight away starting the feeding on this patient. So you need to start hydration with the help of some IV fluid, and for that you need an IV cannula. So after the airway, breathing, circulation assessment, you go for putting an IV cannula, give some IV fluid. Then once the IV cannula is there, take some blood samples, send the basic blood test like your total hemoglobin, total blood count, differential count. You go for your electrolytes, you go for your renal function, you go for your liver function test. See, you don't know, there can be some hepatic issues also. So see, from the history only, you cannot go for the diagnosis straight away. However, whatever characteristic the pain might be, but you cannot straight away go for the diagnosis. So once your IV cannula is there, once your fluid has been started, get some blood sample and get an ABG also. Patient is an HDU setup, patient is not stable, so go for a mildly unstable, so go for an ABG also. Along with that, patient is giving some history of breathing difficulty, go for a chest X-ray. Patient is giving a history of epigastric pain where the underlying cause can be cardiac also. Patient can be having an inferior wall MI. Patient may not have any abdominal issue. Patient may have an inferior MI that you don't know. Just from history, you cannot rule out that. So go for a ECG, basic ECG, go for a echo screen. You need to plan in that way, and then go for imaging like ultrasound abdomen. These are the basic things you can also plan. This doesn't need any special idea to develop. These are the very basics. So the idea of today's discussion will be sticking to the basics. Most of the managements you can manage well without the help of any other person if you can stick to your basics. Always remember that. And lastly, if any organ support is needed, you need to involve the doctors to go for organ support. Can be any cardiac support, can be ventilatory support, and all those things can be planned later on. So initially the basic, check your airway, breathing, circulation, put a IV cannula, start some IV fluid, send the basic blood samples, get an chest X-ray ECG done, get an ultrasound abdomen done, along with go for a echo screening also, or ask your staff. If you're not trained, you can ask your colleague to go for a screening echo to look at the heart condition grossly. So that's how your management strategies goes. And once all these things being sent, think about some differential. So see, you can take actively part in the management. That is what happening everywhere across the world. The nursing practitioners are actively involved in the diagnosis and management of the patient condition. So think about differentials. Patient is coming with an acute onset of abdominal pain. Patient is having a recent history of ERCP. There can be something related to gallbladder. So what can be the underlying cause? Patient can be having some acute cholangitis, infection of the gallbladder can be there, acute cholecystitis can be there, can be a hepatic abscess. You never know. All these things are possible, though there is no proper history of fever or chills and rigor. So all these options might be ruled out. Then patient can have acute pancreatitis, as we were discussing regarding the characteristic pain history. Patient can have a perforation also, but usually in the perforation, the abdomen may not be that soft. A patient can have appendicitis, but usually in appendicitis patient, the location of the pain usually located towards the lower part of the abdomen. And patient can have some renal stone also, but normally in renal stone, the pain is never fixed to a particular area. Usually it's a shooting pain from loin to groin, as they say very classically. So, but that's how you should develop the way of thinking. So it's not that only the patient is coming, will do all these things in a machinery way. You also try to think what can be the underlying cause. So that's how you should try to develop some differentials. And you can discuss with your colleague, you can discuss with your nursing colleague, doctor colleague, anyone. And sir, this is the way I'm thinking, or friend, this is the way I'm thinking. So what can be the other options? So this developing a DDs, developing a differential diagnosis formation is very important whenever you are seeing and initially resuscitating an acutely unstable patient for any condition. I would suggest to go ahead with this differential diagnosis assessment. So when you are busy in assessing the differential diagnosis, when you are busy with sending the initial resuscitations, the reports have started coming, and I am showing only the positive reports. You have initially resuscitating the patient, you are thinking about the differentials, and you have seen some investigation. Mostly it has been done in the bedside. And among those investigations, the positive investigations I would like to show, this is the chest X-ray, this is the ECG, This is the blood report, positive blood reports, and this is the ultrasound which was done in the bedside. So here you can see that in chest X-ray there is mild blunting of the costophrenic angle. In the ECG you can see there is some sinus tachycardia is there. In the lab test there is a significant rise in a particular enzyme. There is a lipase and the amylase are pretty raised, along with mild rise in the total count, total WBC count. And the abdomen is showing some sort of features of pancreatitis. There is edematous pancreas as the radiologist is reporting. So these are the positive findings you can see in the patient when all those tests were done. So with this what about these enzymes, this lipase and amylase? Why does it important? Why are these important? These are mostly related to pancreatitis, but not always. There is a fallacy. So serum amylase usually rises within 12 hours, 6 to 12 hours on the onset of the symptoms. And the other enzyme, which is more specific, usually what we say, the lipase rises around 4 to 8 hours from the onset of the symptom. But why amylase is not very well advised? Why we don't prefer amylase? Because it gets falsely elevated in many of the conditions. So if you want to diagnose pancreatitis, although the definition says amylase or lipase, but remember your stress will be more on the lipase, because between these two enzymes, the amylase and the lipase both getting released from pancreas as such, but amylase can be falsely elevated in many other conditions other than pancreatitis. So it can get elevated in macroamylasemia, it can be elevated in acute kidney injury or chronic kidney disease, it can be elevated in diseases of salivary gland or other condition of the abdominal like acute appendicitis, cholecystitis, all those conditions. It can be elevated in diabetic ketoacidosis also. So amylase will be raised in many other conditions, but lipase will be raised mostly in the pancreatitis. So between amylase and lipase, try to give more stress on lipase, try to give more importance on your lipase. If lipase is more than 3 times of the baseline, then definitely you should think of some sort of pancreatitis getting developed underlying. So remember, in the lab point of view, when you are thinking of pancreatitis, look for your lipase, whether lipase is elevated 3 times, at least 3 times from its baseline value. Remember that part. So how do you diagnose? With this, we come to the next question. How do you diagnose acute pancreatitis? So acute pancreatitis can be diagnosed if any two of the following 3 criteria is present. I'll show 3 criteria. Among these 3 criteria, if 2 criteria is present, you can diagnose the condition as acute pancreatitis. One is a characteristic abdominal pain. The characteristic we were discussing in the first slide only when the patient was giving a classic history. So presence of a characteristic abdominal pain or presence of pancreas specific enzymes, that is your amylase or lipase, more the lipase. I give, as I was telling, lipase will be having more importance, but how much raised? At least more than 3 times of its baseline value. And third thing, radiological evidence. Usually in the definition by means of radiological evidence, they say ideally you should go for a contrast CT, but many a times it is not being done. So ultrasound also many times detect a presence of suspected acute pancreatitis. So to summarize, how to diagnose acute pancreatitis, you need to get 2 of these 3 criteria. Either you get characteristic abdominal pain, or you get a raised specific enzymes level baseline 3 times of the baseline, or you get some radiological findings suggestive of acute pancreatitis. Any 2 is present, you can go for acute pancreatitis diagnosis. Now next comes, once you have diagnosed acute pancreatitis, how do you know it is severe or not? That is again, that is very important question, because depending on the severity, your management plan changes. If the patient goes into a mild stage, or if the patient goes into a severe pancreatitis, severe acute pancreatitis, the management plan completely changes. The aggressiveness, the time span, you know, you are already late. If the patient is coming with a severe acute pancreatitis, you are already late. You need to go fast. You need to be more aggressive. So grading of the severity is very important, and for that we have the standard 2013 revised Atlanta classification. Why revised? Because in 1992 you had the Atlanta classification, where they have 2 types of pancreatitis, mild pancreatitis and severe acute pancreatitis. But in 2013 they revised the classification and they added one in between stage, that is moderately severe acute pancreatitis. So don't get confused. It's very simple. focused on the revised Atlanta classification, there are 3 grades of acute pancreatitis. It can be mild, moderately severe, or severe. So what happens in mild? In mild acute pancreatitis, there is neither any local complication of pancreatitis or there is any features of organ failure. Now, what happens in moderately severe acute pancreatitis? There, usually you might have local complications. We will see what are the local complications of acute pancreatitis. And additionally, there may or may not be transient organ failure. Patient can have developed some organ failure, which is for a brief duration. And when this organ failure is persistent, more than 48 hours, this organ failure is present, then the patient goes into severe acute pancreatitis. That is why I was telling, if the patient is coming late, like already 48 hours is over at home, and then patient is coming in a severe acute pancreatitis state, then definitely your management plan changes. That's why grading of the severity of the pancreatitis is very important. And how do you assess the severity of the organ failure? There is something called modified Marshall scoring system. Very simple parameters I'll show. So depending on that, you need to classify the severity of the acute pancreatitis, and accordingly your management plan also changes. Any other criteria? Just a quick point. When a patient is having a recent history of ERCP and subsequently developing pancreatitis, any other criteria for that? And there is something called Cotton's criteria. In 1991 it was invented. This criteria is specific for post ERCP pancreatitis patients only. And but don't get confused. If you want to think of which criteria you need to follow for the assessment of the severity of the pancreatitis, how severe the acute pancreatitis is, if you want to grade the severity, simply follow the revised Atlanta classification. So assessment of the severity of the pancreatitis has to be done with the help of revised Atlanta classification. Second take-home point. Third, any risk factor for post ERCP pancreatitis? There are many. There are some definite risk factors like sphincter of OD dysfunction, and there are many other, female gender, previous pancreatitis, and all those things are risk factor for post ERCP pancreatitis I'm talking about. Over, not going into details in that. Now coming to the common causes in general of acute pancreatitis. When a patient is getting acute pancreatitis, what can be the common causes? There are many. There can be gallbladder stone, there can be alcohol, there can be hypertriglyceridemia, like your lipid profile derangement. There it can be genetic also, it can be drug induced also, it can be traumatic also, and as in our case it can be post ERCP also. There are many other causes also, like biliary sludge, biliary obstruction, etc. Hypercalcemia is a very important cause. You need to check for calcium, is very important. When you need to focus on any particular electrolyte in a pancreatitis patient is the calcium, so think of that. So coming to the incidence or common incidence of these causes, as you can see, gallstone is the commonest cause for pancreatitis, followed by alcohol, chronic alcoholism. Then hypertriglyceridemia, there is a lipid profile derangement, or ERCP. These are sometimes drugs also, surgical complications. These are also somewhat common as a causative factor for acute pancreatitis. Mechanism, what happens? Usually there is an early inflammatory changes in the pancreas that causes of acinar cell injury and ductal cell injury, and basically that causes premature activation of the trypsin. Trypsin is an enzyme which get activated prematurely, and it causes auto-digestion of the pancreatic tissue. Trypsin is getting released from pancreas, and it is causing an auto-digestion. After getting released, it is eating the pancreatic tissue. So this trypsin, which is getting released from pancreas, is eating the pancreas itself, and then because of that auto-digestion of the pancreatic tissue, there will be attraction of the different macrophages, and there will be cytokine release, addition molecules, oxygen-free radicals will be released, and patient will go into acute inflammatory state. There will be a severe inflammatory response syndrome-like situation, and if properly not managed, patient can go into infected stage, sepsis, multi-organ failure. Everything can happen. So that's how usually the cascade get activated in the brief as a pathogenesis. So going back to the revised Atlanta classification, as you can remember, in these 3 types, mild, moderate, and severe, there was one factor was common, that assessment of the organ failure, whether the organ failure is present or not. In mild, there was no organ failure. In moderate, you had a transient organ failure, and in severe, you had a persistent organ failure, persistent for more than 48 hours. So how do you assess organ failure? I told there is something called modified Marshall scoring. So this is that modified Marshall scoring where you are getting very simple parameters like respiratory parameters is the PaO to FiO2 ratio, renal parameter is the serum creatinine, and cardiovascular parameter you are getting the systolic blood pressure. You grade accordingly, and if the score is more than 2, you can assess it as a presence of organ failure. So if it is getting persistent, then it is severe. If it is transient organ failure, then it is moderate. And if there is no organ failure, then it's a mild. Remember. So how these points I need to focus very small. There are many other scoring system for the severity of the acute pancreatitis, but what you can see, most of them are having a very high negative predictive value. So basically, although this Apache 2 and or Ransons are all pretty common scoring system, even the modified Glasgow score also, but you cannot diagnose on the basis of that. Rather, in the bedside, I would like to focus you on a particular score which you can assess and calculate very easily, and that is called bicep scoring. Bicep scoring, B stands for BUN. BUN is blood urea nitrogen. It is done in your labs, I'm sure. Then I is impaired mental status. S is presence of systemic inflammatory response syndrome, that is presence of SIRS. A is the age more than 60 years or not. And P is the pleural effusion. So bicep scoring, you can assess standing at the bedside only. Look for the BUN value, look for the mental status of the patient, look for features of SIRS, whether the SIRS feature, you know, there will be tachycardia, bradycardia, there will be hypotension, or there will be raised counts, there will be raised temperature or hypothermia. All those SIRS features, look for those. Then look at the age, look for presence of pleural effusion. If 3 to 5 points are there, then the chances of the mortality is very high. There is a severity assessment for bedside severity assessment for acute pancreatitis. So this bicep scoring you should remember whenever you are assessing severity at the bedside. What will be the prognosis of the patient? How bad the patient is once you are done with your revised Atlanta scoring. Now, when to admit in the ICU? There are some specific criteria. Remember this slide where you have either revised Atlanta classification, you can follow that, or Society of the Critical Care Medicine from US. They have given some basic clinical features like pulse rate less than 40, more than 150. If the blood pressure is low, like less than 80, systolic blood pressure. If the tachypnea is there, the respiratory rate more than 35. Sodium is low, potassium is low or very high. Sodium is very high, less than 110, more than 170. Potassium less than 2, more than 7. PO2 is decreased, pH is acidotic or grossly alkalotic, glucose is grossly deranged, calcium is highly, I told the hypercalcemia is one of the factor. You will find calcium is very high, patient is having no urine output, patient is going into coma. So in those situations, definitely you need to think of shifting the patient. You have to shift the patient to ICU. So these are the criteria. The patient is coming to your ward, patient is coming to your HDU, when you will be shifting the patient to ICU. So if the patient is following this criteria as nicely guided by the Society of the Critical Care Medicine US, so then you definitely have to think of shifting the patient to ICU. No confusion in that. Early ICU management strategies, very simple, nothing big things. Remember these three: monitor the vital organ function, look for, that is one, check for the vital organs, how the vital organs are functioning. That means what is the consciousness level, what is the cardiac function, how is the respiratory status of the patient, or what is the urine output of the patient. So those things, vital organ assessment, that is one, monitoring. Second, supportive therapy. Acute pancreatitis usually needs supportive therapy in the beginning. So supportive therapy with fluids, analgesia. Patient will be having severe pain. We are discussing about the severity of the pain. So along with the fluids, you need analgesia also, and some sort of nutrition needs to be started very early. And third thing, screen for possible complications. These are the early, means first 4 days of ICU management in pancreatitis. And what are the late management strategies? You look for the complications, whether the complication is developing. If the complication is developing, then how to manage those things. These are the basic plan of late ICU management. So this patient, when you are managing the HDU, gradually worsened and fulfilled those ICU transfer criteria. So patient got shifted to ICU. How do you manage now? The management plan, again, stick to the basic, go for the airway breathing circulation, see whether there is adequate airway patient can able to manage, patient can how is the breathing pattern, how is the circulation status, how is the blood pressure, urine output. See, assessment of the clinical circulation status is very simple. Look for the mentation. How do you assess whether the circulation is adequate? Look for mentation, whether the patient is conscious, alert, oriented or not. Look for the hemodynamics, like what is that, is there a tachycardia, pulse rate is low, high. If there is a hypotension, look for the extremities, whether it's a cold clamp extremities. Look for the urine output. These are the classic clinical features of your circulatory status. So capillary refill time, those things you can assess in the bedside only. So airway breathing circulation followed by adequate analgesia. The pain will be severe, so if you don't relieve the pain, patient will never be comfortable. So pain relief is very important in the initial management of the pancreatitis. Along with that, fluids, electrolyte correction, and go for enteral feeding as early as possible. So there is a basic management plan now as the patient is getting shifted to ICU. Now, how much fluid? That is a very important question. That traditionally, that you might have heard that pancreatitis, if the patient is coming with pancreatitis, give fluid, give fluid. Yes, partly correct. You cannot make the patient dry, but at the same time, you cannot make the patient die with fluid. So fluid needs to be given, but judiciously. That is very important. So usually the choice of, I don't know what happened in this write up, sorry for that, but what was written there is the balance salt solution. So the choice of fluid usually is your balance salt solution, most commonly Ringer's lactate. You can think about others also according to your availability, plasma light, cabinet, so many else are there. But balanced salt solution has a good combination of sodium, potassium, and everything. So that is a choice of fluid for pancreatitis initial management. But it should be goal directed. You cannot keep on giving fluids just like that. Initially, you start giving, see the response. If the patient is fluid responsive, with the help of POCUS, with the help of your clinical assessment. POCUS means point of care ultrasound. That is your bedside ultrasound assessment. You might have seen many of your colleagues will be doing. They will check the IVC, they will screen the cardiac contractility, and then accordingly they will give fluid. They will look for tachycardia, they will look for blood pressure. So what are the changes on those? So give fluid, see for response, then again decide about the further fluid. That's how you should go for the fluid management. And an adequate fluid status can be assessed if patient heart rate is coming down, blood pressure is improving, urine output is improving, the hematocrit is mostly stable. More the patient is dry, hematocrit will go up. So if the hematocrit at a stable level, then definitely it shows your resuscitation is getting well managed, and the renal function parameters also getting stabilized. So these are the basic plans for initial management. I don't want to go into detailed theory discussion of this fluid management, but still I kept this slide. There are 3 slides on this. This is a particular study. This is not my favorite waterfall actually. This is a particular study that came up in NEJM in 2022, where they compared aggressive fluid and less fluid in acute pancreatitis management scenario. So one group they wanted to compare whether giving aggressive fluid is helpful or not. So in one group they gave 20 ml per kg bolus, other group they gave 10 ml per kg bolus, like that. And see what they found. They found, see the primary outcomes in that study. Just one trial I kept for the sake of discussion. Remember the take home message on this trial, nothing else. I'm not asking you to read the trial, go, nothing like that. Just to have an idea, you should also keep on reading journals around. Huh? There is nothing like no harm in that. So what they found, the primary outcome, the moderately severe acute pancreatitis worsened, as well as the secondary outcomes like patient ICU stay, respiratory failure, organ failure persistent, even death. All those things were more with aggressive fluid resuscitation. So the take home is aggressive fluid doesn't always help the patient. So it has to be judicious. What is the reasonable approach? Reasonable approach as per the patient response. Like go for, as I was telling, POCUS assessment, give some fluid, assess the fluid responsiveness, and then again decide about the further fluid. That is first thing. And secondly, don't go beyond these. All these things are happening in the first 24 hours. Once first 1 or 2 days is over, think of reduction of the fluid. Patient should not get high fluid even after 2 days. You should be thinking about fluid reduction once first 1 or 2 days is over. And if patient is hypotensive, instead of keep on giving fluid, start NORAD early. Remember that thing that has come in the sepsis guideline also. So if the patient is hypotensive after initial fluid challenge, don't delay in starting the NORAD. Patient, the NORAD might stop later.
Dr. Santanu, I think two candidates, they want to interact. Okay,
But sir, should I interrupt now because we are running short of time? I thought I will finish and then discuss.
Okay.
Or should I stop now?
Right,
I can
right.
interrupt.
I
What
think
should I do?
no,
I
you can.
have some
I
notes
think
like,
since they are asking and it is interactive session,
great.
so you
I'm
can take the
ready.
question.
Please. Tell me.
Yeah, whoever is asking question, please ask the question fast. Someone has raised hand. Okay, Dr. Santanu, go ahead.
I think I should go ahead. Yeah, fine. So the reasonable approach is don't follow anything blindly. Give your fluid, see for response, then again decide about the further fluid. That is one thing. Second thing, after the first day or two is over, now think of reducing fluid. Don't keep on giving fluid. That is second thing. Third thing, don't hesitate to start your vasopressor early. We are not getting, we should not be frightened about vasopressors. If the patient is hypotensive, even after reasonable fluid resuscitation, reasonable fluid challenge, reasonable fluid bolus, then definitely go for starting your NORAD or something as per the patient requires. So these three things, remember: response, check response. Second thing, don't go over jealous. And third thing, don't hesitate in starting the vasopressor. So remember these three things in your fluid management. What about pain control? It's very simple. Multimodal, you can give some analgesics, oral analgesics, you can give your IV analgesics, you can give a regional analgesia also with the help of epidural analgesia, particularly in ERCP patient. Epidural analgesia will be of significant help. So, but pain control is extremely important. Never forget the importance of pain control in acute pancreatitis management. It is as important as your fluid management. Patient will be absolutely uncomfortable. This pain is very severe and it increases with time. So definitely be very particular about your pain management. What about nutrition? Nutrition, again, no confusion should be there. Although patient is having abdominal symptom, although patient is having abdominal tenderness, although patient is having abdominal distension, still enteral nutrition is the key. There is nothing called TPN for pancreatitis unless and until patient is not tolerating enteral nutrition. What about the route about the enteral nutrition? First choice, if it is a mild condition, go for your enteral direct oral feeding. It's a mild pancreatitis, go for oral feeding. If it is a moderate to severe pancreatitis, as once the pain is subsiding after 1 or 2 days, after first 24 hours, you can think of starting your enteral feeding with the help of a nasogastric tube. There is no additional advantage, as you can see in this reference also. There is no additional advantage of nasojejunal tube putting. So your normal LG tube is sufficient. So if the patient is moderate to severe pancreatitis, after the initial resuscitation, start early enteral feeding with the help of your nasogastric tube. And if nothing is working, patient is absolutely in ileus, progressively abdominal distension, absolute pain, not vomiting, not tolerating feed, then only think about TPN. So first choice, oral feeding. Second choice, NG feeding. If nothing is working, patient is worsening, hemodynamically unstable, then only later on you can think of, although hemodynamically unstable is not the criteria, but not intolerance to enteral feeding is the criteria for parenteral nutrition. That is always a second choice. That is always a later choice. Never think of TPN in acute pancreatitis. The route should be enteral. No confusion in that. Coming to the antibiotics, there are a lot of theories about antibiotics. Some people are in favor of antibiotics, like they say it's a necrotic environment. So if you don't give antibiotics, patient will deteriorate faster. And there are some people against it also, like people will say in the collection, all those things that is developing there around the pancreas, the antibiotic will not reach even. So what is the point of giving antibiotics? So a lot of controversy on that. So if you really need to give, I'm coming when you need to give, but just if you really need to give, think about something which has a good penetration in the pancreatic tissue. So there you will have this imipenem, sometimes meropenem also. You have metronidazole. Metronidazole is a misnomer. Remember, this is the antibiotic which can cause pancreatitis. One of the causes of drug-induced pancreatitis is metronidazole, but at the same time, it has a good tissue penetration and good anaerobic cover, as you all know. And the other, along with imipenem, the other group which is important for pancreatitis is fluoroquinolone, but usually it is a reserved drug, so usually you don't give. And aminoglycosides and all doesn't penetrate the pancreas much. But when to give antibiotic, that is the most important. normal standard giving antibiotic is not followed as per the international guideline. So only if there is a features of infection or the patient is unstable, then only you have to think of giving antibiotics. So what should be the approach? So if the patient is not in the initial phase, if the patient is deteriorating over the days and you are finding some sort of collection around the pancreas, you aspirate, go for FNAC. If the collection is coming positive from the microbiology point of view, then definitely start antibiotic. If patient is not having any positive culture, but patient is absolutely unstable and there is some gas bubble in the CT scan, repeat CT scan being done, and then also empirically you can start antibiotic. That is how antibiotic should be started. So never, even if your doctor is starting antibiotic early in a acute pancreatitis, ask your doctor, sir, what is the indication for starting antibiotic in this patient? Because I have been taught that antibiotic doesn't have any absolute role in the beginning of management of the acute pancreatitis. So remember, only if the patient is complicating with the features of infection or a suspected infection and instability, either patient is unstable with suspected infection, that is one, or patient is having a definite infection, then only think of antibiotic. Otherwise, no role of antibiotic in acute pancreatitis. Coming back to our patient is better on the day 12. Patient is being planned for shifted out of the ICU, and patient is whatever antibiotic was there, everything has been stopped. No antibiotic is there. Patient is not having any antibiotic. But as you all know, ICU is always dramatic. It doesn't go as we think. So on the next day, the day when the patient is getting planned for shifting out, you find patient is having new onset symptom. There is fever, there is some sort of tachycardia, chills and rigor, increased abdominal tenderness, abdominal pain. Patient is otherwise stable, but tachycardia is worsening. Urine output is somewhat maintained. So patient is not stable. The patient was stable one day back. Today, patient is getting planned for shifting out, but patient is unstable now. So what to do? What to do? So here, think about something additional along with your ABCs and everything. Think about some sort of complication is getting developed. So send your cultures. Patient is having fever and all. Now send your cultures, blood cultures, urine culture, whatever you send. Procalcitonin is somewhat controversial because procalcitonin I'll not discuss much, but on the basis of raised procalcitonin, you cannot start antibiotic. Remember that part only. So if the procalcitonin is raised, doesn't mean you will start antibiotic. Remember that part. So procalcitonin is controversial, but definitely you should send culture and you should go for some imaging, fresh imaging. What imaging you can do fresh at the bedside? Ultrasound. And later on, I'll come to that. And along with that, patient is unstable. So go on, keep on your resuscitation. So all ABCs, fluids, everything will be there. Oxygen, whatever is needed, you would go ahead with your resuscitation. Along with that, send cultures and plan for some fresh imaging. These are the three things: resuscitation, cultures, and imaging, fresh imaging. On the bedside, ultrasound is showing this, some collection is there around the pancreas, small collection, as you can see here. And that's why you followed up with some more imaging, that is the CT scan. And here you can see, as you can see here, there is some good amount of collection around the pancreas. So resuscitation was continued, vasopressors were needed, antibiotic were escalated, proper monitoring was started, including intra-abdominal monitoring. I'll have 2-3 slides on that also. And along with that, the most important part, if the patient is having some sort of infection or collection, then until and unless you source control, do the control of the source properly, patient will never improve. So that's why you have to put a radiology, CT guided pictal placement was done. So along with the resuscitation, antibiotics, vasopressors, cardiac support, monitoring, you do a source control with a CT guided pictal placement, and then patient gradually started improving. So what are the common causes of hypertension in pancreatitis? It can be related to the SIRS, it can be related to the leaky capillaries, it can be related to the severe third space losses. All those things can be local complications, those things, or development of abdominal compartment syndrome. All those things can cause hypertension. And what about the causes of hypoxia in a patient? It can be ARDS, pleural effusion, pulmonary edema. All those things can cause hypoxia in such patient. And coming to that abdominal compartment syndrome, intra-abdominal pressure is raised, somewhat I was discussing. So this is a few, only 2-3 things about that. Intra-abdominal pressure is something we need to monitor because it has widespread effect in all the systems of the body. So intra-abdominal pressure is the steady state pressure inside the abdominal cavity, closed abdominal cavity. The pressure which is there is intra-abdominal pressure. It should be normally less than 12, less than 5-6 actually. But if it is going beyond 12, then definitely it is intra-abdominal hypertension. And if it is going beyond, the intra-abdominal pressure is more than 20 with some sort of organ dysfunction, then it is an abdominal compartment syndrome. And there you need to think about some abdominal APP, is the abdominal perfusion pressure. Remember this part, abdominal perfusion pressure is the difference between mean arterial pressure of the patient and the intra-abdominal pressure. So the difference between these two, it should be more than 60. Always remember this. These are the few cutoffs. Intra-abdominal pressure should be less than 10, abdominal pressure should be less than 10, and abdominal compartment pressure should be more than 60 to maintain a proper intra-abdominal condition. So why I was taking so much stress on this, because intra-abdominal hypertension has so many effects on the central nervous system. It can changes mental status. On the cardiac system, it has effect, deteriorating effect. In the renal function also, it deteriorates the renal function. Pulmonary function also, it deteriorates. Liver function derange. There will be local blood flow derangement. So intra-abdominal hypertension, if the pressure within the abdomen goes up, then there will be widespread effect on the different parts of the body. So you need to control the intra-abdominal pressure. No confusion in that, because in our patient, because of the local collection, the intra-abdominal pressure is going up. So you did, along with your resuscitation, you did a local drainage with the, you put a pigtail with the help of a CT. So with the pigtail placement, the local collection got drained, so the pressure was decreasing. So intra-abdominal pressure management is very important. How do you measure intra-abdominal pressure? It is measured with the intravesical method. This part is important. Remember this part. Probably many of you are doing it regularly. You put a catheter with the normal Foley's catheter inside the bladder. When the bladder is empty, the standard is the mid-axillary line with the patient in the supine position. You inflate the balloon of the catheter with around 25 ml of water, not more than that. They say it's a maximum 25 ml. That is being given in the latest guideline also. And with that, you look for the pressure. It should not be, as we are discussing, it should not be more than 12. It should be less than 10 only. Normally it remains around 5 to 6. So monitoring intra-abdominal pressure is very important with this method. Not your abdominal guards and all those things are not reliable. So always monitor intra-abdominal pressure with this technique, as many of you are doing also. So I'm not going into the management of the status. What are the major complications you should look for acute pancreatitis? Acute kidney injury. These are the gross complication. One is acute kidney injury. The renal function is deranged or not, getting deranged or not. These are, I'm talking of the complications. Monitoring of the complications of acute pancreatitis. Patient is already in a state of acute severe pancreatitis. So what are the complications you should look for? One is your kidney effect, if the patient is developing acute kidney injury or not. Second is respiratory effect, if the patient is developing acute respiratory distress or not, and abdominal compartment syndrome also getting developed or not. These are the general systemic complications of acute pancreatitis, and there are some local complications also, as I was discussing initially. The local complications can be acute pancreatic fluid collection, can be acute necrotic collection. From the acute pancreatic fluid collection, patient may develop some pseudocyst. From acute necrotic collection, patient may develop some walled off necrosis. Usually the acute pancreatic fluid collection or acute necrotic collection develops within the first 4 weeks, and the pseudocyst and the walled off necrosis develops after more than in the late phase, usually more than after 4 weeks usually it develops. So
Dr.
these are
Santanu,
yeah,
Dr.
sir.
Santanu, please give 10 minutes to the candidates who have joined.
Yes, yes,
so
I'm over, because our questions are also there. I'm over. These are the basic management plan. I mean, pathogenesis at the pancreatitis goes off, and this is the basic management plan of pancreatitis. So that's how with the weeks patient progress, and that's how where you need to intervene with your fluids, antibiotics, later on initial fluid analgesia, organ support, everything. That's how the management progresses. So with this I would like to conclude, and once you are done with your questions, one bad thing is that we have 5 questions for you also. I have, so we'll discuss those 5 questions. I need your response on that one by one. So I'm happy to get questions now, and subsequently I'll ask the questions. There are 5 questions for you. Should I proceed with my questions, or?
I think there are there's nothing in the chat box also.
Yes, there is one question. Pancreatitis life-threatening? Yes, it can be.
Yeah, I have responded to that.
Okay. So let us go with the questions. I have kept basic questions.
Yes.
First question: what is the most important common criteria? What is the most common criteria for the assessment of the severity of acute pancreatitis? Anyone can answer. Among these, one option is correct. How do you assess the severity of acute pancreatitis? Please, someone respond. I'll be waiting for the response only. Yes, as many of you are responding, C is the correct answer. It's a revised Atlanta classification. The Atlanta classification was there older, but it has been revised, and the 2013 revised Atlanta classification is the correct answer. Correct. The response I got in the chat box. Next question. What is the most common cause of acute pancreatitis? There was a slide where I have shown the percentage of the causes. Gallstone also cause, alcohol also cause, drugs also cause, ERCP also cause. But which one is the most common? Can anyone answer in the chat box? Yes. A. Correct. 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 All are giving A. Very good. So gallstone is the most common cause of acute pancreatitis. Excellent. Third question. Sorry. Which enzyme is characteristic of acute pancreatitis? Like when you want to diagnose pancreatitis, acute pancreatitis, you will rely on which enzyme, whether it is amylase or lipase or gamma glutamyl transpeptidase or SGOT. Which one is more specific for acute pancreatitis? That's my question. Anyone can respond on this? Yes, lipase. Perfect. So I got some response in the chat box. Lipase is the correct answer. Very good. I'm so happy. Next question. Role of antibiotic in acute pancreatitis. What is the role? How do you use antibiotic in acute pancreatitis? One option is there is no role of antibiotic. Second option is you need to start it as early as possible. Third option is start antibiotic only there is if there is complications, infection related complication is present, only then you start. And fourth option is once the management is over, you are discharging the patient towards home, then you start some oral antibiotic. So which is the correct answer in this question? A, B, C, D. Oh, excellent. Here also all the correct answers are coming. It is C. If there is infective complications developing because of acute pancreatitis, then only think of antibiotics. Otherwise, in the initial stage, there is no role of antibiotics. Very good. Fifth question. This is the last question. How much fluid will be given in first 3 days? Like your patient, you are managing the patient for the first 3 days in your ICU with acute pancreatitis. So can you name any value or whatever? There, one option is correct among all these four. How much fluid to be given? Either it is 10 to 15 ml every day. You are giving 10 to 15 ml per kg, or every day you are giving 15 to 20 ml per kg, or every day you are giving 30 ml per kg, or you are not following all those values, you are rather following the ultrasound or point of care ultrasound, and depending on the fluid responsiveness you are giving fluid. What is the correct answer? Excellent. Excellent. D. Very good. So I'm so happy that you actually answered all the options correctly. That shows you listened to it attentively, and definitely you had your prior knowledge also, which is correct. I'm so happy that you got all this take home point. I would like sir, I would like to request sir to give his concluding remarks on that. And if you have any queries, I'm very happy to answer.
Dr. Santanu, thank you so much for very elaborately discussing the topic. And it appears that all the candidates, they also had, they have taken the message that you wanted to give, and they responded very well to the question that you have posted for them. A few things that I'd like to mention here is that in the differential diagnosis, they should also consider that patient could be having MI. Okay, so anything near the pancreas, all organs should be considered that that they could be having some disease process which is giving this kind of pain. Okay, epigastric pain. The second thing is that if the gyphoid process is pressed, then there could be a tenderness there, and in the backside also below the 12th rib, near to the vertebra below the angle, okay, that is pressed, there also could be some tenderness in pancreatitis. There could be some bluish discoloration around the umbilicus. There could be a reddish brown discoloration in the flanks. So these are also some of the presentation, might not be present in all the patient, but that should be kept in mind. And if the candidates can remember all the scoring system, this is well and good. If not, at least follow the early warning system that the nurses usually follow in the ward setup, okay, and for shifting the patient to ICU. But if you can remember the scoring system, that is well and good, that Dr. Santanu has presented, and specifically the Atlanta score, if you remember, that will be quite good. Okay, so I thank Dr. Santanu for very good presentation, and that has been very well appreciated, I think, based on the response that has been given by the candidates. Okay, so thanks a lot. Thanks for giving us the opportunity to interact with the nursing candidates who actually are the backbone of the intensive care unit.
Thank you, sir. Thank you, everyone. And still we are there. There are a few minutes left. If you have any query, I had one query. I've answered that regarding the antibiotics. If you have any other query, please ask here, or you can open up, like you can speak out also. You can write on the chat box. We are all waiting here. We are there to clear out your doubts so that your basics remain very strong. If your basics are strong, you can manage all the conditions, not only pancreatitis. So focus on the basics only. I guess nothing, no more questions are there. So let's conclude this.
Yeah.
Thank you, everyone.
Okay, right. Bye.